Good evening, everyone. My name is Kashif Siddiqui. I'm a consultant urologist and have been asked to talk about men's health during this week by UPMC. Men are generally considered to be kind of ignorant about their health matters. You can talk to them about cars, about travel, but unlike women, they don't like to discuss about their health matters. But certainly, we need to be aware of certain things that we have to look after as we progress towards aging. One of the things that I want to focus on today is the prostate-specific antigen, which is, in simple words, is a blood test. It's a protein which is produced by prostate epithelial cells, both benign and malignant, and the function is to liquefy the ejaculate, enabling fertilization. It is present in semen, urine, and blood. It is available in the form of complexed PSA and also free PSA, which is not combined to any proteins. The PSA value changes with age, and according to the current National Cancer Care Programme in Ireland, a normal PSA is 0 to 2 for all men between ages of 40 to 49. The normal range increases to less than 3 in men aged 50 to 59, which goes up to 4 in 60 to 69, and should be less than 5 in all men above the age of 70. PSA testing has been looked at as part of screening in multinational European and American trials, and it has not been recommended to use it as a tool of screening. However, many men these days are well aware of it and would request a PSA test. And plus, the diligent general practitioners have included this as part of the routine check after a certain age. The recommendation would be that PSA should be checked in men after the age of 50 and after the age of 40 in those who have a family history of prostate cancer or other risk factors, which include African descent or first-degree relatives. So if the patient requests, certainly I consider doing the PSA after counseling them. And there's a few things that we need to know about what can PSA lead to. We would always do their prostate-specific antigen testing if they present with lower urinary tract symptoms, if they have an abnormal examination of the prostate, or in advanced cases of prostate cancer, they can present with progressive bone pain, back pain, unexplained anemia, anorexia, or weight loss. There could be cases of spontaneous thromboembolism or unilateral leg swelling, which is commonly called as deep venous thrombosis. And certainly a pelvic malignancy like prostate cancer should be ruled out in those situations. And plus also patients who have been diagnosed with prostate cancer and are on treatment or after treatment, we have to monitor their PSA on a regular basis. The counsel I recommend before doing anybody's PSA is that cancer will only be identified in less than 5% of men. So PSA testing does not necessarily lead to cancer diagnosis. It is very important to understand that its sensitivity is 80%. In other words, PSA comes from the prostate and nowhere else. But the specificity of PSA for prostate cancer is only 40 to 50%, which means that it could be high because of many other reasons. For example, benign prostatic hyperplasia, which is something that I will address later on this evening. We need to inform our patients, and you need to know that prostate biopsy could be uncomfortable. These days, the trend is moving towards transperineal biopsies, which are generally done under general anesthetic. But in many centers of UK and US, this is being done as outpatient procedure under local anesthetic, and it's only a matter of time that we will be moving towards it. The main advantage of transperineal biopsies is the reduced risk of sepsis. Previously, and even currently, there are centers which are doing transrectal ultrasound-guided prostate biopsies, which obviously run a risk of infection, and up to 2% of significant infection, so much so that it may require hospitalization. Repeat biopsy may be recommended. So once off doing a biopsy is not enough in some cases. Treatment may not be necessary, and that would mean that even if someone is diagnosed with prostate cancer, they would be, or they could be, a suitable candidate for active surveillance or watchful waiting in elderly population. Treatment may not be curative, because if the cancer is picked up at an advanced stage, you may need a multimodal treatment. However, in this current age, we have many treatment options now available. Prostate cancer management has changed completely in the last 10 years, with many advanced treatment available now in Ireland and all over the world for advanced diseases. We need to know that there is a morbidity related to treatment, whether it be surgery, radiotherapy, or other novel treatments, which may lead to diminished quality of life. So doing a PSA may be the start of something that may end up in a very different manner, which the person requesting the blood test should be aware of. MRI scan has developed significantly, and now these days it's a common practice to do MRI before doing the biopsies. Certainly the PSA blood test, followed by MRI, and then a biopsy. But where did the old style digital examination went? We know that the digital rectal examination of the prostate is very important because it increases the positive predictive value. It helps us to identify the abnormalities on the MRI and correspond it to our clinical findings. And in many situations, the clinical examination raises suspicion even with normal PSA. And that is why I think it is important not to let go this vital piece of clinical examination. As I mentioned earlier, that PSA is prostate specific, but not prostate cancer specific. And this is one message that I want you all to take home from tonight's talk. It could be high because of many reasons. Benign prostatic hyperplasia is perhaps the most common reason, and every man will get BPH as they age. Histologically, after the age of 40, and anatomically, the changes start to happen after the age of 50. Urinary tract infections are a common cause of high PSA, and sometimes they could even go very high in the hundreds range, where one would get very concerned that, am I dealing with prostate cancer or just as a simple thing as UTI? But you'll be surprised to find out that after treatment of the infection, the PSA falls right down within normal range, and that is why we recommend that PSA should always be repeated 6 weeks after the initial test before any definitive action is taken. Acute prostatitis is quite common in men of the age of 40 and 50, and that would be a common cause for high PSA in those men. Chronic prostatitis can also lead to that. Urinary retention, catheterization, instrumentation, all of those things can lead to high PSA values. Certainly the biopsy or surgical intervention on the prostate as well can lead to high PSA values. So the message that we need to take is PSA is important to get checked. We need to know as to what we are heading into, and always remember that high PSA does not necessarily mean prostate cancer. As I mentioned to you, that PSA generally increases with advancing age. PSA is used in management of prostate cancer in diagnosis and staging of prostate cancer, counseling and monitoring of prostate cancer patients. There are different numbers, and it might be a little bit complicated to go through all the details, but in general, the values of PSA at different ranges mean different things for the clinicians. Because as the PSA goes higher, the risk of locally advanced disease, which means cancer going outside the prostate or cancer involving the other organs around it, is higher. Prostate cancer usually goes into the lymph nodes first and also the bones. And as the PSA value goes higher, the risk of spread, whether locally in the regional area or distant metastasis, which includes bone and lymph nodes in other parts of the body, is also very important. This is mainly for the clinicians to know the different values and make assessment accordingly. There are a number of things that you may come across during a consultation process with your general practitioner or a urologist or another physician. As I mentioned earlier, that PSA is available in the complex form and also the free form. And the free to total ratio, if less than 25%, is favorable. PSA density is calculated with the PSA values and the prostate size. And when the density is less than 0.15, the direction is towards benign conditions, whereas when the PSA density goes above 0.15, the concern is about cancer. What it means is that if there is a very large prostate gland, then even a rather high PSA can give rise to low density, which means low chances of cancer. Whereas a high PSA in a small gland may increase the density and a high risk of prostate cancer. When we are monitoring patients, whether with prostate cancer or even during the time when the biopsies are awaited, PSA velocity certainly plays a role in our decision-making. And the rise of PSA every year when it is more than 0.7 is considered to be significant. PSA doubling time after radiotherapy is also considered as an indication of intervention if the PSA rises very quickly, to look at other novel treatments or alternative treatments in those who have had prostate cancer treatment. From here on, I would like to take you on to another part of male health, which is a number of symptoms that we would all experience as we age. And this would be related to the benign prostatic hyperplasia. Male lower urinary tract symptoms, commonly known as LUTS by us, the physicians. It is a complex composition of overlapping symptoms. And in general terms, these can be divided into the voiding symptoms like straining, terminal dibbling, slow stream, hesitancy, or even intermittent flow, or storage symptoms, which include urgency, nocturia, which is waking up at night to pass urine, and increased daytime frequency, or even the post-micturition symptoms, which is the dribbling that happens after the voiding flow is completed. It could be caused because of multiple conditions. And as you can see on the slide, that LUTS, or the lower urinary tract symptoms, is right in the middle of all these possible causes, because they all present with different combination of symptoms. A single person may not necessarily have all the symptoms, but whether they have storage symptoms, or voiding symptoms will direct our investigations and thought process towards different conditions. Some of the common ones in this are the benign prostatic enlargement, or BPE, or benign or bladder outlet obstruction, BOO. Like you can see that overactive bladder or detrusor overactivity, which is just the hyperactive bladder muscle leading to frequency and urgency. It is commoner in women, but can also happen in men secondary to bladder outlet obstruction. As I said to you earlier, prostatitis is quite common in men. Bladder stones are an indication of bladder outlet obstruction. Bladder tumor can also lead to these symptoms, and that is why the necessity to do flexible cystoscopy, or at least to look into the bladder, is important in assessment of lower urinary tract symptoms, particularly when there is blood present in the urine. Urethral stricture or narrowing in the passage of urethra or scar formation can also lead to slow flow, dribbling, and frequency. Any foreign body is, although it's thankfully not uncommon, but we do see it from time to time, can lead to symptoms related to infection, like frequency, urgency, burning, and then there are conditions like underactivity of the bladder or neurogenic bladder, which is to do with the nervous control of the bladder muscle. Nocturnal polyuria is a very typical condition where more than 1/3 of the urine volume is produced at night time. It is slightly different to nocturia and may have other reasons to look into. The male symptoms are usually dealt with at the primary care in the first, at the beginning. Obviously, a careful medical history, which is always taken by the general practitioner, is vital to assessment, like I indicated before, that the symptoms related to storage, for example, going frequently or urgently or waking up at night, may mean just irritable bladder rather than an enlarged prostate. But if they have voiding symptoms more than irritable symptoms, which means slow flow, hesitancy, double voiding, all these would be signs of obstruction or benign prostatic hyperplasia leading to bladder outlet obstruction. Physical examination is done at the primary healthcare level. Urinalysis can be done, and like I said earlier, that PSA level is common enough to get done these days. In most cases, a medical therapy can be initiated, but if the symptoms don't resolve, if they get complicated, then obviously patients have to be referred to a specialist. And me, as a urologist, we do certain other healthcare questionnaires to understand the symptoms better. We do a uroflow study in which Qmax is the maximum flow rate, which should be at least more than 15 mils per second. It is important to know the average flow rate as well, the post-void residual, because if somebody is not emptying their bladder properly, then that can lead to frequency and also even leakage at night. Ultrasound of the upper urinary tract, which is the kidneys, is important because the back pressure of what is retained into the bladder can potentially damage the kidneys. And that is why the renal profile or the blood test for the kidney function is also done in these situations. Urodynamics study is a very complex examination and specialized examination, which is not part of the routine initial assessment. It is indicated in very young or very old people with a combination of symptoms which could be misleading and mistaken, whether they are because of the bladder or from the prostate obstruction. And as I said earlier, that endoscopy or the flexible cystoscopy is important to rule out bladder tumor and to assess other possible causes of symptoms from the bladder mucosa. This is just a depiction of what benign prostatic hyperplasia does, which every man would develop. and the changes, as I said, start to happen histologically after the age of 40 and anatomically after the age of 50. On the diagram on the left-hand side is the normal bladder with the normal prostate in the yellow and a passage of the urethra, which is wide open, through which the urine flows. But as you get older, you can see that the bladder on the right-hand picture becomes thicker because it is working over time to push the urine out through the obstruction, which is caused by the enlarging prostate, diminishing the space between the lateral lobes through which the urine passes. These symptoms obviously have a substantial health burden, and men are quite bothered because as it starts after the age of 50, when they are working, when they are active socially, when they start to notice that there is some sleep disturbance, sexual dysfunction, they start to worry about it. It can have an impact on physical and mental health, but not only that, but it may have implications for the future as well. The symptoms may get worse, or they can even develop complications, for example, acute urinary retention, which may require surgery sooner rather than later. Medical therapy can be initiated at the level of primary care, and usually the objectives are to improve the symptoms quickly and also, along with that, improve the quality of life. It is also the long-term desire from the treatment to maintain symptoms at bay for a longer length of time and to reduce the prostate volume and the risk of complications, which as mentioned, are acute urinary retention, repeated episodes of blood in the urine, or infections. The two drug classes that are available are alpha blockers, or commonly known as tamsulosin, Zatral, Urorec. You may have heard about these. They're usually initiated at the level of primary care as well. And the whole purpose is to block the alpha receptors, which are present in the prostate lining, to help with the urine flow. Or in the longer run, there are the dihydrotestosterone, the 5-alpha reductase inhibitor, which decreases the dihydrotestosterone synthesis, which in turn reduces the size of the prostate gland by reducing its sensitivity. There are drugs available with a combination treatment of an alpha blocker and 5-alpha reductase inhibitor, both at the same time, which has shown that there is reduced risk of urinary retention and other complications related to benign prostatic hyperplasia. As I mentioned, that the alpha blockers would work on improving the urine flow and the quality of life, and they usually start working pretty much straight away. But the 5-alpha reductase inhibitor take a longer time to start working. And at least it takes 3 to 6 months before any effect is noted. If somebody does not respond to medical therapy, then there are a number of surgical options available. The surgical management is indicated in patients who show progression on medical treatment or present with complications of BPH or benign prostatic hyperplasia, like I mentioned, acute urinary retention, repeated episodes of blood in the urine, infections, or even renal failure. If a person elects to forego a trial of medical therapy because they can't tolerate or they have issues with compliance to medical therapy, and then there would be those who would like to receive a more definitive treatment and get this sorted for once and for all. Surgical treatment can sort out the problem for longer duration, but many people would need a repeat surgery probably in 10 years down the line. The indications for surgery at the outset would be acute urinary retention or chronic retention due to prostate obstruction, which can present with renal failure, recurrent urinary tract infections or hematuria, which is blood in the urine, or bladder stones, which is usually formed because of prostate enlargement. Renal insufficiency or abnormal renal function can also be because of urinary retention. A bladder diverticulum, bothersome LUTs persisting after medical therapy, or indeed the patient preference are indications to go for surgery at the outset. The number of surgical options available, of which the transurethral resection of the prostate, or TURP commonly called. Now we can do this with the bipolar energy as well, which is the transurethral vaporization in saline. Certainly the transurethral incision or the bladder neck incision is an option for younger men. The lasers are being used for many things these days. And in prostate, the green light laser is used for vaporization, or the holmium laser is used for enucleation for larger prostate glands. All of these are available in many centers across Ireland. Open prostatectomy is not commonly used these days for benign enlargement of the prostate and is reserved mainly for cancer cases. However, in some cases, rarely, we do have to revert back to this operation, which was invented by an Irish urologist and is still being done by some. Thank you very much.
Thank you very much for listening there to Mr. Siddiqui, and Mr. Siddiqui is going to take some questions now. So the first question we have there is from Jared, and he's asking, is there a more specific test than PSA called PSE available now?
Jared, this is not available widely. There have been other tests which have been used in clinical practice, but not available widely. And unfortunately, although you must have reflected in my talk as well, that PSA has a high sensitivity but a low specificity, which doesn't make it an ideal test. But unfortunately, that's the only one which is available widely to the general population.
And we have another question in there from Brian saying, what is the importance of the family history for prostate cancer?
So the importance, it increases the risk, Brian. And for example, if you have one blood relative who has prostate cancer diagnosed, then your risk is almost twice as much as anybody else of your age in the community. But if the same number, if you have multiple blood relatives who have prostate cancer, then your risk of having cancer yourself could go up to 5 times. So certainly that is important to know. And that also, keeping that in mind, the National Cancer Care Program and all the other authorities around the world as well, that they have brought down the age of people with family history of prostate cancer to start checking their own PSA at a much younger age. For example, in Ireland, we would do PSA from 50 onwards, but if somebody has got prostate cancer history in the family, they can ask for a PSA test from 40 onwards. Okay. So that certainly can make a difference. And the whole idea is to pick up cancer earlier so that it is treated well and can be cured.
And I suppose obviously if at any age, if you do have symptoms the indicative of prostate complications, you would go to your GP as soon as possible and be reviewed.
Yes, Gwen, and the symptoms now with prostate cancer specific symptoms, unfortunately, they appear very late. For example, with advanced prostate cancer, with low risk early prostate cancer, the symptoms don't appear very early, but many of the GPs are now doing PSA as part of routine health check for the eligible population. And certainly, if anybody goes to them with lower urinary tract symptoms, they would invariably get their PSA checked, and very rightly so.
Excellent. And what are the surgical options for managing benign prostate?
So, like I mentioned briefly towards the end of my presentation, previously we used to have the transurethral resection of the prostate, which is use of a monopolar current. But now they are much better and also much safer techniques that are available throughout various hospitals, including the UPMC system as well, because we can use laser. We have the green light laser, which is for laser vaporization. We can use holmium laser for enucleation. We can use the bipolar transurethral resection in saline, which has got which has no limit to the time frame that resection can be done, because traditionally the monopolar resection was limited to be done within the 60-minute time frame. But with bipolar resection, even with larger prostate glands, can be operated for longer duration without any major side effects or without any major complications. The TUR syndrome, the bleeding risks, the transfusion risk, all of those are reduced with these newer techniques. The public must have heard about the resume treatment as well, which is the water jet therapy, which we are also using as well. And that would be very helpful. And that's very, very effective in use in younger population with lesser sexual dysfunction side effects of that. So these were the options which were all not available until about maybe 10 years ago, 15 years ago, but now they're widely available and we have alternatives, which are as good as transurethral resection in many ways.
And I suppose it is important to mention that across the 11 urologists that work in the UPMC network, all of those treatment options are available, but it's very much bespoke to an individual patient and their condition. So people some options are available to some and not to others. So it is really about, meeting with your consultant and deciding the best care plan with them.
Yes, absolutely. Because, for example, with the use of laser, the big advantage is that can be done on anticoagulation. And certainly, like you said, that it's not that everybody is suitable for every technology. And that is why a hospital is compelled to provide different options because they are for different patients with different type of prostates and different type of symptoms. But it's good to have the options available across the board and to be able to offer those to our patients when we're dealing with benign prostatic hyperplasia.
Yeah. Just one more question, Mr. Siddiqui, a more general question. In relation to preventative measures for prostate health, what role does health and nutrition play?
So, Gwen, I think as general as this question is, I think general would be the answer, because health improves the outcome of many diseases and avoids many illnesses to happen. There were some studies done in terms of prostate cancer, but I'm not aware of any definite direct link which we can say with certainty to do or not to do. There were studies where obesity was linked to prostate cancer, where the outcome of treatment of prostate cancer was linked to obesity to have a worsened outcome. So certainly one should not be obese. There were studies that were looking at tomatoes, selenium. There were studies looking at exercise and healthy lifestyle, which has shown to have some impact. So all of these general measures would have an impact in general towards your health and in turn also towards the prostate cancer. But the two major risk factors for prostate cancer are not related to diet, but they are more related to the family history and the African origin.
Okay. And I suppose it is important to mention that, if you do have a condition that needs a surgery, your overall fitness, the better it is, the better you will recover from that surgery and the better candidates are for anaesthetic. So just general overall health and well-being and looking after yourself, exercise and a healthy diet will help your overall condition and recovery from any procedures that you may require due to prostate issues or cancer.
Without a doubt. And that stands across the board along all other illnesses and all other operations as well.
Okay, listen, thank you so much, Mr. Siddiqui.